Good morning, everyone. My name is Elizabeth Brewington. I am the Associate Director for Partners in Health and Wholeness, focusing on overdose response. We're so happy to have you here with us this morning. Today, we are going to be having our sacred conversation focusing on HIV and women. For those of you who are new to Partners in Health and Wholeness, we are an initiative of the North Carolina Council of Churches and have been around for the past 11 years. And we work with faith communities in their health ministries, connecting health as an issue of faith. We're going to be having another webinar next week to give you more information and background about Partners in Health and Wholeness, and I will stick the registration link to that in the chat. But we are so glad you are here with us today, and we hope that you will stay involved with us. I will now hand it over to my colleague, Nicole, and she's going to open us in prayer.
Hi, good morning, everybody. I'm Nicole Johnson, the Associate Director for Denominational Engagement and Special Projects. And I invite you to join us in an opening prayer. At the end, I'm going to say, Lord, and then everyone can respond, hear our prayer. There are sisters and brothers in our community that are in need of healing. We don't know who they are, and some of them are. Walls of silence keep us apart. Some are fearful to speak the name HIV and AIDS. God, bring us all to a truly safe place filled with compassion and understanding. Bring us all to this place of safety, that your church may embody your spirit of protection and healing. And what part do we play? Show us the way to make a difference. Guide our hands to hold the first hand. Open our hearts to receive the first hug. Remind us that you have chosen us. Remind us that we can help. Awaken the spirit within us, the spirit that is mine and yours. Your spirit refreshes the soul with serenity. Your soul embodies the heart with courage. Your spirit charts our right course with wisdom. Help us to break down the walls of separation within our community. Help us build bridges of love and understanding. Help us sweep away the debris of the isms, phobias, broken connections, and shattered hopes. Prepare our hearts to prepare your way. Encourage us to think the first thought, to make the first sound, to speak the first word. Help us to break the silence. Lord, hear our prayer.
Hear our prayer.
And that prayer, I will say, is it was taken from a prayer from the General Assemblies of the Presbyterian Church USA, from a part of their Presbyterian Social Witness Policy compilation called We Will Break the Silence, the Bomb in Gilead, if anybody is interested in looking up those prayers and those kinds of worship tools. So thank you for joining us today, and I'll hand it back over to Elizabeth.
Thank you, Nicole. So I will now introduce our speaker, Courtney Keola. Courtney has over 20 years of nursing experience that includes practice in women's health and public health in both domestic and global settings. Courtney has translated her passion for nursing practice into nursing education and research. She is currently an assistant professor at East Carolina University College of Nursing. Her career commitment is to improve the health outcomes of women at risk for or living with HIV by examining and addressing the social and economic determinants of their health. She is dedicated to using community-engaged research methods, reducing HIV stigma, and ensuring women of diverse backgrounds are included in her research. Courtney's current federally funded research project aims to increase HIV care and engagement and medication adherence among women living with HIV. When Courtney is not teaching or doing research, she enjoys spending time with her family and friends and visiting the North Carolina mountains where she was raised. Thank you so much for being with us today, Courtney.
Thank you. I'm going to share my screen real quick, and Elizabeth and Nicole, thank you for the introduction and the beautiful prayer. And thank you to everybody for this opportunity to be in this space and be part of this sacred conversation with you all today, and talk a little bit about this important topic. I look forward to being in spaces like this because my work and my research occurs in a secular space, which I respect very much. But I was personally brought to this work and continue this work through my personal faith journey, including 3.5 years when I and along with my husband and my 3 children worked as medical missionaries in rural Southeast Uganda. And that was really where I gained an understanding of the HIV epidemic from a global perspective, and have continued that in my work here in the States. So I'd like to begin today by just trying to paint a picture for you of the way in which HIV is currently impacting women in the United States and in our local communities. Sorry. So what you see here is the lifetime risk of HIV in the United States by state, with the darker states indicating higher risk. So as you can tell, people living in the Southeast region of the country clearly have greater risk. In fact, the South accounted for more than half, about 53% of all new diagnoses of HIV in the United States in 2019. So this epidemic has become somewhat concentrated in our country in the Southeast. And that's a change over the 40 years that we've been working and striving to help people with HIV in this country. And if you'll recall from the flyer for this particular conversation, it cited that according to the Office of Women's Health, that 1 in 4 people living with HIV in the United States is a woman. And that is true. But here in North Carolina, it is actually slightly higher. So there's over 1 million people in the United States living with HIV. About 33,000 of those are in North Carolina, and about 28% of those are women. And so that's roughly about 9,000 women in our North Carolina communities living with HIV. And heterosexual contact is the primary means of transmission among women. About 80% of the time, HIV is transmitted through heterosexual contact, and it is for women. And that is true both here in North Carolina and across the country. But one of the more disturbing or concerning things to me is how the disparate health outcomes among women. And so Black or African-American and Latina or Hispanic women continue to be disproportionately affected, with the rate among Black women being almost 14 times higher than white women, and the rate among Latina women being almost 4 times higher than white women. And then once living with HIV, Black and Latina women are also likely to die earlier from AIDS complications than their white counterparts. But I want to take pause here because I always am a bit wary of reporting statistics by race. I think it can obscure the fact that Black and Latina women are disproportionately living in poverty more often than white women in the United States. And we know there are a lot of social and historical reasons for that. The percent of Black and Latina women living in poverty is more than twice that of white women in the US. And there is very clear epidemiological evidence linking poverty and HIV diagnosis rates. So if a person is living in poverty, not only are they more vulnerable to HIV infection, but if they're living in poverty and living with HIV, they're more likely to have poorer health outcomes due to factors like healthcare access, lower educational levels, and those kinds of important social factors. another aspect of this problem is the number of people living with HIV that engage in care, take their medications, and stay in care. And what you see here is generally called the HIV care continuum or cascade. And as you can tell, we have some work to do when it comes to getting people into HIV care and retaining them there. And what this slide doesn't reflect is that the viral suppression rates of women in the South are the lowest in the country. And what we mean by viral suppression is women taking medications and it reducing the HIV viral load in their systems, so in their bodies, so that they are undetectable. And that is a direct result of being in care and taking your medication. So the third aspect of this problem, and I'm returning to this slide, is really the nature of HIV itself. Unlike most chronic illnesses, HIV is infectious. And so because of this, even 40 years into the epidemic, we still deal with a great deal of social stigma and negative connotations related to HIV. And stigma is of particular consequence here in the South. Research shows that key indicators or contributors to the high rates in the South are those issues of race and class and gender inequality that we just talked about, but also they cite HIV-related stigma as contributing to these rates. And what we know about stigma is that it contributes to or is associated with poor mental and physical health outcomes across a broad range of demographic profiles, not just women, but all people living with HIV. So it has significant impact on people's experience. And when we think about women, HIV-related stigma is also of great consequence to women that are mothers. So many of the women living with HIV are both mothers and living with a chronic illness. And so what does that mean for her? Our research tells us that women living with HIV that have families have higher stress levels managing their own health and their healthcare needs than women without families. Mothers also have more difficulty carrying out their daily activities required of their role as a mother due to things like fatigue and the physical limitations that can sometimes accompany living with HIV. And mothers living with HIV are also driven by a concern called courtesy stigma. And courtesy stigma is essentially as it sounds. It's the stigma that children can endure, courtesy of having a mom living with HIV. And so as a result, moms will often protect their children or attempt to protect their children from the stigma and not disclose their HIV to anyone. And what that does is it reduces their social support and increases their social isolation, which we know is also impactful in people's health journeys. So one caveat to this, and one thing that I'm very interested in my research is how motherhood can also be something that women living with HIV cite as a reason to live and a source of strength for them. So motherhood, in a sense, if you will, is a two-sided coin and very interesting thing to think about specifically when we think about women living with HIV. So hopefully I've given you some sense of the current state of HIV among women and how it disproportionately impacts certain communities. Some of the social factors like HIV stigma that continue to drive this epidemic. And these social factors or determinants intersect in different ways and can be really complex, very hard to study. But what you see here is something my research partners and I developed based on the concept of intersectionality to try to illustrate this complexity. And intersectionality is grounded in the work of African-American feminists and social scientists. And it really offers a means for us to examine intersecting social and economic circumstances in people's lives and see how those, their role in producing health inequities. So I encourage you to close your eyes for a minute and kind of imagine yourself at a busy intersection in a city, and across the street is, you know, your ticket to happy and healthy, but you have to cross this intersection diagonally. And so that's what we've tried to portray here is you have a woman literally standing at a traffic intersection with her 2 children in tow. And what she brings to that intersection are all of her individual characteristics. Her racial identity, her gender identity, her socioeconomic status, her HIV status, and the children she's raising. So, and her challenge is to get across that intersection safely, protecting both herself and her children, and hopefully thriving, being healthy and well-being. So the roads that you see here are the literal intersection. Those are how the world responds to her identities, if you will, in certain cases. And so those are those social determinants that can intersect at the middle, at the intersection of the roads that create vulnerability for people, for women, and a susceptibility to poor health. And we call it mutually constituted. What we mean really is just it's jointly determined. So when we use intersectionality to examine things, we don't assume that, you know, race, gender, and class inequalities kind of accumulate to create a triple threat, if you will. They really vary as a function of each other, depending on the particular gender or race or class that an individual belongs to. And the more that we understand these things, the more fully we can begin to understand how it impacts people's health. So I just wanted to give a couple of examples from my research. This is a response from a woman I received from a woman who was in one of my prior studies. And when I asked her about her experience of being a woman living with HIV, and she said, I don't know, it's like a lot of people. For a Black woman, to me, they find out you're HIV or AIDS, and you've got to have been a prostitute or had to have sold your body or considered a little bit like nasty. Yes, you just can't let everybody know. It's not that I'm ashamed of this, but there's a lot of cruelty out there, you know. And so she describes a very specific experience related not only to just being a woman, but specifically being a Black woman. You know, when we present ourselves in the world with all of our identities, and you can't kind of separate them out. And she's experienced a very specific kind of stigma related to her identity. And so this participant denied that this or similar experiences have ever caused her to not go to care or access treatment, but she did state that it has significantly impacted her mental health and how she copes with her HIV and taking care of herself. So I want to pause here for a minute once again and kind of revisit this visual, because I think there's a real temptation with a visual like this to view a person or a group of people based on their vulnerability. And that's where the bridge comes in that's going over the intersection. And it was really our way of trying to attempt to describe the multiple meanings of these women's lives and not just view them as being vulnerable, but also having a lot of resilience and strengths. And so, again, we know from the literature and the scientific literature, but also my own research, that being a mother or motherhood can be one of those positive influences and positively impact a woman's ability to navigate that intersection and her subsequent health outcomes. It can be that reason for her to live. It can be because she wants to protect her children. And so just like motherhood, a person's faith life, their church family, their spiritual journey is another thing that we have found that may positively influence women and their ability to navigate this intersection toward better health. And I have a feeling that that's no surprise to the folks on this call. But hopefully you find it interesting that the scientific community is also recognizing this as well. And we encourage you to think about your faith community as one of those potential bridges in the lives of women toward better health.
Hey, good morning, Chris. I'm doing all right, sir. How are you?
Good morning. It's funny because I never ask participants specifically in my research study to talk about their faith or their spirituality. But these responses that you see here are to the question, what in your life helps you take care of yourself and your HIV? And faith and church and spirituality come up over and over again as a theme in my work. And one of the ways I try to elicit information from women is through photography. And sometimes a picture can truly tell a story, 1,000 words, right? What's that saying? A picture can say 1,000 words. And so I ask participants to take photographs to help tell their stories, to help center their voices, and explain things to me about their experiences. And so the following are examples of photos and quotes from women living with HIV in my research. And as an example, this participant said, I've been in the church since I was a baby. And, it's been my whole life through church. I think my church family and God has kept me alive. And another participant talked about her church community and said, they don't judge you. They don't look at the color of your skin, your race, nothing, and your health, sick or bad. They welcome you open hands. And these are just a few examples. I hear these kinds of statements over and over in my work, even though I'm not explicitly asking about faith or spirituality. These are the things that women talk about that help them care for their health. And so that said, our faith communities are made up of people, and they can be like any other segment of society and perpetuate HIV-related stigma. So for example, this December, I was interviewing a woman in our current study, and she told the story of how she had confided in someone in her church community about her HIV status, and that person told the church leadership, and she was no longer able to work with the children in her church. And so this was a woman who had worked very hard to stay in care, take her medications. She was virally suppressed, and there was really no way she could transmit HIV to anyone in the community. But so that was a difficult experience for her, and although she is thriving in other ways. So I would just encourage you all, in whatever capacity you are in your faith communities, to educate folks, to address fears, and really help change attitudes about the ways that HIV is transmitted. Talk about the U equals U campaign, which stands for undetectable equals untransmissible, which means that if you're taking your medications and the virus is not detectable in your body, you can't transmit HIV. This is a really important progression that we've made over the years with the really great medications that we have now. And to consider language used when referring to folks, and saying living with HIV rather than HIV positive or HIV infected, and to really model behaviors about encouraging testing or talking openly about HIV, and being particularly sensitive, I think, about the intersectional stigma and the ways in which some communities are disproportionately infected. Because the good news is that we're making progress. We're making progress in this epidemic. So across the board, the new infections are remaining stable among women in this country. And if we keep at it, and if we continue to work on helping folks get in care, stay in care, then we can hopefully end this epidemic. And that's the goal, the national goal for 2030 is to really to end this HIV epidemic. And wouldn't that be a wonderful thing for so many thousands of people? I just want to thank all the women, particularly that I work with who have participated in the research that I do. I have to acknowledge my funders that help me do this research, but also for your time today. And I welcome any questions or conversation that folks might want to have. Thank you.
Thank you, Courtney. If you have any questions, feel free to come off mute and ask them, or you can type them in the chat. I think my first question for you, Courtney, is if there is one thing that faith leaders can do. You talked about stigma, you talked about or reducing stigma, and you talked about education. Like, what is the one thing you would love to see engaged faith leaders do around this issue?
I think modeling behaviors is just so impactful. And so hugging all your congregants, encouraging testing, being tested yourself, those kinds of action-oriented things can really help to reduce the stigma associated with HIV, and I think can go a long way in communities. So I think that would be my suggestion.
Courtney, we did have a question come in. Are there any support groups, or what would you recommend as an educational tool? And quickly before you answer that, I am going to drop in the chat box some resources that we have on our website, but would love for you to answer that as well.
Yes, there are support groups, and it's very dependent on where you are located. Unfortunately, the rural areas of North Carolina, there aren't as many, although they are available. They tend to be kind of concentrated in more the triad regions, but probably the best thing to do based on where you live is to connect with the infectious disease clinic near you, or community-based organizations that really focus. So it's kind of hard to say specifically depending on where you are, but yes, there are support groups, and there's some wonderful ones that have been going on for years in North Carolina that are specifically for women too, because it's clear that women have different concerns and journeys with this particular illness. And so I think that can be really important too.
Thank you. I couldn't find my mute button or my unmute button. Does anyone else want to come off mute and ask a question or type it into the chat box?
Are there support groups for family members of someone living with HIV?
You know, those are not as common that I'm aware of, although a lot of groups will welcome anyone who is interested in supporting folks living with HIV. It's a great question.
So I do a lot of work with substance use and harm reduction. So I was wondering are there any like scripts that if somebody wanted to start their own support group at their church that they could follow?
You know, I honestly don't know, and I don't want to mislead you, but I can certainly look into that, Elizabeth. And if I find something, I'll forward you that information, because that's a great point.
That'd be great.
Mm-hmm.
Apologize if you said this. I was about 10 minutes late.
No
For
worries.
testing, where do we send people to get testing, and/or are there ever where you come to us and do testing? So if we did a big, hey, we'll just do HIV testing today, how can we make that even more accessible?
Sure. So the quickest answer to that is that most communities, the health departments are a really good resource, because they're the most accessible, even if you're in a rural area. In the more urban areas of North Carolina, there's lots of health medical centers that have specific infectious disease clinics that provide testing. I would like to say that it's a regular part of healthcare routines, but it's generally not. Among women, the time that they most often get tested is when they're pregnant. And so there is universal testing with pregnancy. Of course, you can opt out of that, but that is something that is provided. And so a lot of times, unfortunately, women find out that they're a mother and living with HIV at the same time. And so that can be a very difficult experience. But back to your question, Tamara, I would encourage health departments, of course, and then depending on where you are, there are some mobile clinics that will come to on site. But I would, you would want to investigate locally. And I'm sorry, I don't have like specifically, I don't know where you are, but
I'm in Boone. I'm in Boone, North Carolina. And,
my hometown.
Oh, wow. So what was pinging through my head is that our national general synod, which is only every other year, they had a big get tested. And so there was a big booth, right? So that we would all go get tested in that booth. But then I'm like, I have no idea where I would go tested if I'm not at my own big denominational meeting.
Sure. That's a great question. I can forward to Elizabeth the specific resources I know of in Boone or Watauga County, if you're interested in that. But I have to look them up.
Yes, and we'll send a follow-up email with a bunch of resources as well. So any resources you would like to share with us, we'll make sure it goes out to everybody at the end of the.
Awesome. Great. Thank you
for that. And a follow-up question would be for anybody on the screen. How do we get people to go get tested? Have you had any cool motivational techniques? So how do we really promote going and getting tested on a fairly regular basis if you're sexually active? You know, understanding that I might not be the one going and having, but anyway, I'm not going to go there. So how do we promote people? Do anybody have any cool ideas? Does it make sense what I'm asking?
I think at one point, it might have been Annie on a previous call, wasn't it? Who went along with the group of young people.
I did.
Tested.
I did. And you know, at my age and what I did, because no, they were not going. I told the congregation, I said, will you support me? I said, I will go to be tested. Will you come and be tested if I go? And they did.
That is fantastic.
It was so surprised.
I think that's exactly that role
I knew
modeling.
that I was okay, you know, but that's what I did. And we all went together and we were tested. And we had a lot of fun.
I bet you did.
And carrying on. And I never will forget that we had to go up the stairs to be tested. So we were joking, and we said, well, when you come back down, you know, if things are not right, just come down real proper, like everything is just great. And when you get out in your car, have a nervous breakdown and ask God to help you. Oh, so we just had a lot of fun, and it worked out. I think we had about 9 or 10 from the church.
I love that. Thank you.
You're welcome.
Chris and I were at an event and they had testing set up so everybody could get tested. And so Chris and I were like, oh, we'll make a video, show how easy it is. So I was like, I'll go. They could not find a vein. And so Chris is standing there recording the video and I'm just like, yeah. So we're hoping to have that available soon to show how easy it is. I might need to drink a lot more water is what I'm coming away with.
Yeah, and thank you all. Tamara, great to see you. I would just say that, you know, this is a fairly new grant for Partners in Health and Wholeness. but you will see a lot of resources on our website. I put a link in the chat box, and we will continue to develop those. And one of the big things that we are trying to do is to really normalize testing. So, a lot of our faith communities in the collaborative will hold health fairs. Granted, not so many in the last 2 years, but we are starting to see that happening again. And, what we're encouraging is, in addition to doing blood sugar checks and, blood pressure checks, to include this. So really, really trying to change language and just normalize this testing as a screening among all the many, many screenings that we do. Annie's story, I mean, all of us have talked about it in staff meetings and planning meetings, and I think it's absolutely perfect. The whole leading by example. Do you have any other thoughts, experiences, or questions?
I'm just curious about sort of thinking of different ways we can help provide support to people. One of the reasons I asked the question is, are they going to find out right there? And how can we really let people know in advance that if something comes back different than what they expected, that we're here for them, and that, especially at a big testing event where we're leading by example, as Annie so beautifully did. Any thoughts on that?
That's a really great question. And, I think clearly want to be sensitive to the possibility that a test might come back differently than somebody expected, and the emotional consequences of that. And so I think being mindful about first of all, relying on the healthcare providers that have been doing this a long time, and really working with them before the event to understand what their processes are, because they're quite experienced in working with folks and guiding them through that journey of the new diagnosis. And so being as familiar as you can with that process, so that if the person has questions, you can adequately explain to them what that will look like. And so really coordinating as much as possible with the health professionals, I think is critical, because they have those resources in place that you may not be able to provide. And clearly that's super important for folks. That's an excellent question.
All right.
Any other
more questions?
If not, oh, Katie?
Oh, I was just going to make a comment on how just thoughtfully you asked questions of the people who participated, and just really impressed by that. So thanks for all of the work that you've done and the research that you've done as well. And thanks for presenting to us today.
Oh, thank you. I appreciate that very much. It's a pleasure and an opportunity. I really appreciate being here. I love the work you're doing. I think it's fantastic. So nice to see this council together, really focusing on the health and well-being of folks. So it's great. Thank you.
Well, thank you all so much for joining us today. I'm going to hand it over to my colleague Krista to close us out in prayer.
I'm going to do a little bit of two things. I know we usually do like 3 deep breaths, and then I have a very brief kind of benediction of sorts for you. All right, so if everyone kind of just wants to relax their shoulders, Get your feet on the ground if you can. I'll count off the first breath and then you can take the other two on your own. 1. And as you continue on into the rest of your day, I'm going to share a snippet from a benediction from Reverend Darcy Rourke from titled Each of Us Ministers to a Weary World. Each of us ministers to a weary world. Let us go forth now and do that which calls us to make this world more loving, more compassionate, and more filled with the grace of divine presence every day. Amen. Thank you, everyone.
Thank
you all.
you.
Thank you, Krista.
Thank you.
Have a blessed day.
You too. Bye-bye.
Bye-bye. Thank you.
Bye, everyone.